So what is melena? I mean, we have referred melena with all sorts of kind of stool and descriptions, and patients sometimes are a bit vague. The definition of melena is jet black, sticky, tarry stool. It's offensive smelling. Okay. Jet black is the darkest shades of black, for those who don't know. And tar is a very thick liquid that's used to cover road surfaces, and its original form is coal. Okay, and on the next slide, you'll see what that looks like. And this would be kind of what we'd sometimes see on a patient's bed. And I think that's probably one of the best pictures I've seen of something that looks like melena. So although I mentioned earlier, solid black stool is not, shouldn't raise alarm bells straight away until you've excluded other causes. In the context of known chronic liver disease, black stools, even if formed, coffee ground vomiting, I think should be referred for inpatient admission. They need an urgent gastroscopy. The reason is that varices can bleed intermittently. So patients might have a large volume hematemesis and then not bleed for a day or two, and then have life-threatening bleed after that. So just be aware. In terms of patients with inflammatory bowel disease, just be aware constipation can trigger off a flare of colitis. Avoid codeine. That's probably one of the most constipating opiates around. If their pain is because of their inflammatory bowel disease, then try and make sure they are engaged with their IBD team in hospital, as the underlying issue needs to be dealt with. Most of the time, opiates make things worse rather than better in inflammatory bowel disease. If you're thinking the patient's having a moderate flare and they're already on maximum dose of this, or they're on azathioprine, and they can't get a hold of anyone on the same day, might be a Friday afternoon or a bank holiday, then you might want to consider oral steroids. I mean, sometimes we see patients 2 or 3 months down the line in clinic, and they say, oh, we got better, the GP gave me a course of steroids, but then I started flaring again. And then I asked them how long did they give it to you for, and they'll say 3 days or a week. We give steroids for 2 months, usually, if we're going to treat them for a flare. So if you're convinced the patient's got bloody diarrhea, you don't think they need admission, then consider a decent course of oral steroids. So while I was preparing this talk, I came across an article where someone suggested Michael Jordan might be jaundiced and needs to see a liver specialist. Just be aware that certain ethnicities that have increased carotene in their eyes below the conjunctiva, which makes it seem a bit like jaundice. Just ask the patient: is this normal for you? Do you feel well? And consider an urgent blood.
Often with cases like this, there's not a single factor which has triggered. It's usually multiple factors that have come together and created a critical situation. And if we're just looking for single things, just looking for, say, a blood count and thinking about infection, or just looking at allergy, we might miss things which are there, and they're going to hinder the patient's recovery. So I always try to approach this as being a detective, and we're going to try to look at all angles to try and work out what has contributed to this situation, and by doing that, we can make sure we've covered all the possible factors to allow the patient to have the best possible recovery. Because when I'm approaching this, I'm not thinking about the patient, oh, I'm going to try and get you a little bit better, or let's get you out of here and make things better for the next week or the next month. I'm thinking, how am I going to cure you? How am I going to get you back so you can live your life normally and you're not worried about your skin, you're not distressed anymore? That's what I'm thinking about. I'm thinking about a cure. I'm thinking about getting this person's skin back to normal. So in order to do that, if I'm missing bits of information, I'm not equipped to deal with this patient properly because I've got gaps in my knowledge. You have to think about infection, and you're not going to know what's growing, or you're not going to know whether there's infection there or not unless you swab. And I was talking to Khalid about swabbing, and he was just saying how some people don't feel confident or don't know exactly how to do a skin swab. And it's interesting because when I trained at Oxford, and one of the competencies we all the medical students that were attached to dermatology, one of the competencies was they had to do a skin swab. So, I mean, some people think it's so easy. Why do you need to be taught how to do a skin swab? But I'm going to show you how we do a skin swab. Within the swab, you have a little gel, which is the preservative gel. You can pop your little swab into that gel, so you get a little bit moisture, and then you touch the skin. Now, some people, when they're swabbing the skin, they do this. It's like they're scared. Oh, I'm gonna damage something. It's like a sword. It's not. It's just a swab. It's just a bit of cotton. So give it a good rub. You want to put some firm pressure. You've got to pick up there's gunk, there's dead skin above the surface. So you want to be pressing nice and firm and give it a good rub. And I would say about 10 times, just keep going. Because you've got to pick it up. What's the point wasting your time doing that, opening a swab, and you're going to get nothing back?
Any morning stiffness? I like that question. Yes, so there is stiffness it feels stiff in the morning, okay? But what you're going to ask though specifically is how long that stiffness is, all right? Okay, because I mean, who feels stiff in the morning when they wake up? All of you? So I talk to my medical students, imperial students during the week, yeah, and I ask them do they feel stiff in the morning? They say no. They're in their 20s. They don't feel anything. You're approaching your 40s, and 50s. You start feeling stiff. But the question is how long, all right? And this chap is feeling stiff most of the morning, all right. So if it's inflammatory stiffness, what I was saying, inflammatory musculoskeletal problem, then you'll have stiffness for more than 30 minutes usually. But if it's 5-10 minutes, it's probably just degenerative. Okay. Okay.
I would do
Estec you would do?
I would do Estec.
Why do you want to do Estec?
Platelets.
Platelets. Clotting, yeah. Absolutely. I think that's the most important, because with Purpura, there's a broad differential, okay? And I think, if it was me, I think, there's some nasal bleeding as well. I think you need to know the full blood count. You need to know the platelets, because and the clotting, but the platelets probably because of what condition? ITP, okay, ITP. Yeah, so that's one red herring there. Okay, I'm glad you've mentioned that, okay, because so what you have to remember, okay, ANCHOR tests for a specific group of vascular disease, okay, and in my practice, it's probably only accounts for about 10% of all the vasculitis patients I see. So first key point is a negative ANCHOR doesn't mean you haven't got vasculitis, all right? So remember that. So don't get hooked on the ANCHOR, because this clearly has a vasculitis.
And obviously we now have early COVID antiviral drugs. Now, COVID antiviral drugs, depending on where you work in the UK at the moment, probably as a GP, you're not going to have had too much experience prescribing, because you're still sending them to the CMDUs. Most of you will still be sending them to CMDUs. That is definitely going to change soon. The government plan is really to get rid of the CMDUs and move it out into the community. So I'll talk a little bit about COVID antivirals to help you gain some confidence prescribing them. So I point out that I don't always do this, but I do it the majority of time. The key thing is, if you've got a patient with a fever, please take a travel history, because the differential diagnosis changes so completely. I have to say, in my experience is GPs do that phenomenally well. Consultants do that well, junior doctors slightly less well. NHS 111, really not at all. I don't think it's on the algorithm for most patients with a fever for NHS 111. And it staggers me how few patients volunteer the information that they've just come back from abroad. That is particularly common in people who are from that part of the world who've been visiting friends and relatives. Understandably, they don't often really even consider it travel. They're just going back home to see their family. What's latent TB? So latent TB is when you've had TB infection, as evidenced by that adaptive immune response, either a positive MAN2 or IGRA, but you're well. You don't have symptoms, your chest X-ray is normal, and basically you've got the TB living somewhere in your lymph nodes, but your immune system's keeping it all under control. Now, we can give you treatment at that stage, which is shorter than standard treatment. So we either give 6 months of just isoniazid or 3 months of rifampicin and isoniazid, and that reduces your chance of TB reactivation by about 90%. Nothing in medicine's 100%, but it's pretty effective. So that's why we contact screen patients, because if we identify that your IGRA is positive and you've been living with someone, we can get in there with the drugs and get you treated before you develop active TB. Chronic Lyme is obviously a massive, people are very anxious about chronic Lyme disease. There isn't actually a lot of evidence that Lyme disease even exists as a chronic entity and leads people to be fatigued with symptoms for a very long period of time. Certainly if you've got Lyme disease, you often feel tired for a few months sometimes, a bit like EBV really. EBV can make you feel a bit tired for a long time. But chronic disease for years and months, not really. There's not much evidence for that. The thing to do really is to protect your patient from the quacks if they think they've got chronic Lyme disease. A lot of people, particularly in London, go and see a lot of doctors who give them very prolonged courses of IV antibiotics. I see in my clinic, really trying to advise them that's not a good thing to do. And then you may or may not know, but there's other labs in Europe who'll do a whole host of non-proven Lyme disease tests and tell the patient they're positive. And I've seen a lot of patients, sadly, who spent a huge amount of their money sending away Lyme disease tests to prove that they've got Lyme disease. But if you've got someone who you're struggling with, who you thinks they've got Lyme disease, you can obviously refer them to me. I get those referrals quite a lot.